All right, you guys ready for some key laser cases? Okay, so we want to show a key case of routine SLTs. So we got healthy patients in their 50s with glaucoma borderline controlled by 2 meds. Should we schedule an SLT? And if so, for which one? So just look at the angles here. Now we're going to show you a little bit more detail. This is going to be video. Top patient. I don't see a lot of structures, do you? Let's compress. So there's, I guess that's meshwork and scleral spur. So that's appositional. I don't know if we want to do an SLT if it's appositional. So let's go ahead and jump down to the bottom one. So there was the top one. Here's the bottom one. Oh, yeah. There's meshwork. There's scleral spur.
This is an instructive video. If we look at this angle, it looks open.
Yeah.
It looks like we can see pigmented meshwork and scleral spur. And we might do a trabeculoplasty by firing along the anterior border of the pigmented meshwork. And yet, when we indent this eye, we can see that the angle is not open. What we're looking at is a Sample-Aces line.
Okay.
Here I'm pushing with quite a bit of pressure, and we can see a pigmented trabecular meshwork. Deep to the white line that we had identified inappropriately as scleral spur. Here we can see that especially clearly. That is a Sample-Aces line. And when I push, we can see Sample-Aces line, non-pigmented meshwork. Now there's a pigmented meshwork, and we can even see scleral spur. If we had lasered without indenting, we would have welded this angle closed.
Wow, so those guys have appositional angles, both of them, and you had to compress to know. And if you would have just looked and thought that that was meshwork, if it's a Sample-Aces line, you'd have welded them shut. So they need a PI, both of them need PIs. They have, bowed anterior irises, not SLT. So neither of them are candidates for SLT. Let's just show you, what does it look like if you weld an angle shut? That was Dr. Lee Alward, by the way. He was the narrator. This is stuff from his website. This is gonioscopy.org. Look at all those high PAS. That was from a angle laser trabeculoplasty. And yeah, that doesn't really help, does it? So you got to know how to compress. But you know what you also got to know how to do besides the dynamic compression gonioscopy? We're going to show you another one that's really important. Compression doesn't deepen this angle. Does that tell you everything you need to know? How can you tell if you're looking at Sample-Aces line or pigmented meshwork? You really can't, can you? Is that scleral spur right there? Or is that posterior to it trace pigmented TM with high PAS mostly shutting the TM? So that's why you absolutely have to also know the corneal light wedge. They also call it the parallel pipette. I don't like that name. It's just a light wedge. Just looks, you know what corneas look like with slit beams. It's just a cornea. So let's show you a picture. Using the thin slit beam, the optical section helps identify structures. And that's where the cornea ends, way up here. So where you have a Schwalbe's line, that's where the cornea ends, and it's just sclera, and you go from seeing a wedge to just a thin sclera line. And if you have pigment there, it's often pigmented. You can only see Schwalbe's line if there's a Sample-Aces line. It's often inferior. There's not always pigment though. And then you got anterior and posterior TM. Anterior is not pigmented, posterior is. Then you got another white line, scleral spur. Then you have ciliary body. And let's just take a look at this video of Lee Alward. He's going to show us the video of this picture. So this is the inferior angle. They're going to have a normal Sample-Aces line. So there's that extra pigment on the anterior portion. Sample-Aces line, that's where cornea ends. And then you have a little space, so iris. Then we'll go up to ciliary body. Let's jump to scleral spur. Let's then jump up to the pigmented and then the non-pigmented meshwork, scleral spur. pigmented meshwork, non-pigmented meshwork, and then, come on, Lee Howard, you're going slow. And then way up here is the sample lacy line right there. So, let him fast forward a little bit. There's cornea up there. He's just gonna wind this lens around, and you guys should definitely get comfortable with Goldmann 3-mirror gonioscopy, but it's you got to know how to compress and you got to know the light wedge. We're going to show you why. Okay, now what does the light wedge look like? If you don't ever see a picture of it, it's hard to know what you're looking for. But watch, he's going to get it in focus. He's thinning the beam, getting his anterior posterior focus, and you'll see that the cornea, you know what a cornea looks like on optical section. The cornea ends as a thin line right where the sclera or the cornea ends. So there's sample lacy line, and when he gets it in sharp focus, it's amazing. It's kind of fat right now. He's going to thin it out a little. Boom. Drill that into your brain. Look how much space is between the iris and where that cornea terminates. So if that line terminates right where the iris inserts, that's not normal. And so sample lacy's line. Gonioscopy.org has all of that. What if we had no pigment, no landmarks? You absolutely need to know how to do the light wedge. Because if you just look for the pigmented lines, there's none. I don't see anything. It's a young patient. They don't have any pigment anywhere yet. Well, knowing how to do the light wedge comes in handy. Let's watch. Oops. Go. Okay, so let's just watch this. So even though there's no pigment to guide you, if you get good at the light wedge, once you dial it in, just the right angle, just the right thickness, lots of brightness, boom, you can see that there's ample space between sample lacy, or Schwalbe, where the cornea terminates, and your iris. So that's probably an open angle. The more you do it, the more of a feel you get, but you gotta just start doing it. You can only really look at this superiorly and inferiorly. It's kind of hard to do on the lateral angles. Usually, but that gives you at least a line you can start to trace and follow around. So you can even see if it's open with no pigment. Let's look at this case. You got a 52-year-old female. She's got pressure that's just a little high, no meds. She's appositional everywhere, except she's slit to posterior TM inferiorly, just barely open TM, 2+ pigment, and it was confirmed with the light wedge that that part that's open at the bottom is TM. It's not a sample lacy line. Okay, so she's mostly appositional. Probably what she need. Thick brown iris, no bad glaucoma damage, we don't think. Rest of it's normal. Yeah, probably needs a PI, left eye, then right eye. Any concerns? Buddy, that is a perfect storm waiting to happen. Let me show you what I mean. Okay. So compression can tell you if you're looking at an area where the iris adheres, whether it's adherent or not. And they said that they did the light wedge to say, oh yeah, that's a sample lacy line. This is the inferior angle that we could be talking about in this case. So do the light wedge. Yep, that's sample lacy up there, but I do have just a little bit of pigment on my inferior angle down below, so we're open a little bit. This is, oppositional angle closure is at risk. It's narrow angles. We just need to do a PI and deepen the chamber. But remember, you need compression to differentiate. Look how much we're compressing. It barely deepened. What if the superior mirrors didn't deepen at all? If you got even the light wedge, you can tell what structures are what, but you need to also know if you're dealing with PAS or if you're dealing with something that's appositional and can deepen with a PI. If it's appositional, if it's sneaked, if it's got PAS, a PI won't help, will it? It's not going to deepen even with a PI. It's already. What could a PI do here? I said it's a perfect storm. So, what does that say at the top, Ian? My words are cut off by the presenter.
What if there are PAS not, what if these are PAS not just a narrow angle?
So yeah, what if these are PAS, not just a narrow angle? The PI won't help. If a TM is normal in function, how much of the angle must be closed in chronic angle closure glaucoma before the pressure starts to rise above normal? Some sources say 270 degrees. So remember, trabecular meshwork is pressure-dependent outflow. As the pressure tries to go up, it might rev up its production, that little sad angle that's still open. But once you go past 270, it's going to start really going out on you. It's one of the reasons that neovascular glaucoma can say, no spike, wham! And that's because you zippered that last piece of the angle, that last quarter is starting to close. What quadrant closes last in chronic angle closure glaucoma from narrow angles? Usually it's inferior. That's the deepest angle usually. What iris type sheds the most pigment with a PI and give you a big storm? Dark brown irises. Which direction does gravity pull the pigment? Inferior. To help you with your glaucoma problem, we're sending a storm to your only open angle, which is already starting to sputter. There it is, all in the vignette. Let's see what happens. All right, 45 minutes after the PI, 48. Let's throw the kitchen sink at this one, and let's see what the pressure is later. It's going up after we added pressure drops? What next? Dr. Kinzer.
Make sure I said that earlier.
That's right, what we said earlier, paracentesis.
Paracentesis, sorry.
Yes, that's okay. Emergent paracentesis, be careful, they're phakic. The pressure lowers, when are we gonna follow up? You guys know better. Real soon. But the question is, why did this happen and what do we need to do? I'll show you. This patient needs gonioscopy. Those were synechiae. That's not going to deepen with the PI. You're sending a storm to the only open pigment, and it's a big, thick iris, so it's a big storm, and it's overwhelming what it has left. So after you do a cataract surgery, big, thick lens is replaced by a thin artificial lens. Now you can do this. You can't do the synechialysis before you put a new lens in, because the shallow chamber from the crowded lens will just create new synechiae. But watch, I don't see any angle structures. We're going to push backwards. You have to do this under, boom, boom. You have to do it under direct visualization. There's some surgeons that kind of do it blindly without the gonial lens. There's no way you're going to push in the right spot. Boom. We're revealing the TM underneath these synechiae. And it was barely synechied. If it's not uveitic scarring or neovascular scarring, it falls right off. And you don't have to worry about inflammatory debris or fibrovascular membranes infiltrating the meshwork and ruining it. Usually, if it's just appositional, it's just going to fall off, in my experience. And here it is again. Boom. Come to the side here. Yep. And then boom. So you have to really see it. It won't come off until you get just on the right spot. This kind of goes around and around a little bit. Before I tell you the result of that case, I want to show you one more that made us very proud. You think that's bad? Here's another case. PI was given during the day. Patient's got cataract surgery planned. It's like, you're so narrow, we're worried about you spiking when you dilate for surgery. Let's just go ahead and PI you right now. I had so here she goes. Perfect storm spike to 78? That evening, they come in vomiting on max meds. So this one didn't go to 57, this one went to 78. That's a heck of a perfect storm. The Bennett and Bloom resident, on her first ever solo on-call shift, is here to man the service. Matty Adams, our current Elizabethtown and Glasgow doctor. does her first solo 30 gauge paracentesis in a very shallow phakic anterior chamber, gets the pressure down, and then accelerates the plan of, you got a toric lens coming, you're doing that tomorrow, and gets in there. We do the cataract surgery, and the plan is to do gonioscopy with it. And this video I want to show you just because it has a really good view of the gonioscopy. So we throw in the lens, and then look when we get in there. There's a little bit of TM, and then pop, pop, pop. And as we go around, there's another spot where you can really see it. Watch this. Bam! Bam! Isn't that satisfying? That thing is like, it's just slightly Velcroed to the angle. But there's no bleeding. There's no fibrovascular membranes like neovascular glaucoma or uveitic glaucoma. It pushes right off. And I won't belabor it forever. You get the gist. So we go all the way around. So, perfect storm. We'll tell you the results in a little bit. A few tricks. If you think you got a perfect storm patient, we're like, hey, I think all these upper angles aren't just appositional. I think they're sneaked. And I think you just got a little bit of meshwork down here that I don't want to dump a ton of pigment into. First trick, you got to have an argon and a YAG laser. Do an argon first. If you cook and cook and cook and cook the iris before you zap it with a YAG, there's not going to be any bleeding, and it kind of cooks the tissue, so not much pigment releases. It just kind of pops open like a piece of aluminum foil. It's pretty wild. Also, before you do anything, get IOL measurements. So it's got to be at a surgeon's practice that has IOL measurement capability with a cataract surgeon on standby. Because if you spike, they could help you. If it's a mild spike, you got to go in and rinse and rinse and rinse and rinse the pigment out. If it's a severe spike, that meshwork is in trouble. It's like, you just put me over the edge. I can't handle it. I'm going to 78 on max meds, which means the only way I'm coming down is if you expose more of my meshwork to get it working again. And then you're going to watch me, and if that doesn't work, you're doing glaucoma surgery. So get the measurements. Now, why do you want to get the measurements now and not tomorrow if it spikes, Ian? McWhorter, Ian.
I'm sorry, you said
Yeah, I said, so why do you want to make sure you get the IOL measurements now to plan the possible cataract surgery, as opposed to, let's just see if they spike tomorrow and then we'll get them if we need them?
Oh, according to the definition, we would get any accurate measurements.
Pressure of 78 is going to have MCE, microcystic edema, through the roof. You will not get any accurate measurements, so you're just going to have to throw any old lens in there. This patient already had measurements from Maddie, but so yeah, so you're gonna do that. You're going to do gonioscopy, and then we're going to follow up in a week, right?
Oh, we have our first question. Addison, did I say that right?
Yeah, Addison, I did just chat with you. You have your hand up.
Oh, do you have a question?
I'll have her put it in the chat box if she does.
You got us all excited. We were about to start answering questions. That was great.
She was probably going to say, see him back same day pressure check, right? That's what we do for bad glaucomas. We check you same day, or at least the next day. Yep. 2030, 2015, pressures are 14 and 16 on no meds. That's what happened in those two cases of perfect storm. So if you know how to handle it and they got healthy meshwork, you can still save the day if you handle it right. I should publish that someday. We haven't done that for perfect storm, but we have several cases. Only two. We're never going to get any more because now we know how to catch it, right? Anyone can spike. You got to be ready. Any questions? All right. Yeah.
You know, I feel like we used, I feel like the last 7 minutes we should just watch some of your YouTube videos.
We can do whatever you guys want.
Like and subscribe to iNinja.
Yes, please do.
Message to post to make sure they all get on iNinja.
Yeah, it doesn't have very many hits. Like, I only have like 200 something followers. But if you guys help, I would so appreciate it. And then those two cases I mentioned they're really something. And my one appeal I would say to you, the world's going to be what we make it. So there's a lot of doctors out there and the anterior surgeons that just want to do LASIK and cataracts. There's a lot of cherries in our field, but I'll tell you what, man, if you like it when there's a doctor who's there not just for your cherries, but for your pits, the real hard headache cases that make their hair turn gray, and actually pay less than cataract surgery, pay much less than LASIK. If you want to reinforce wherever you go in the country, doctors being there for you, you refer a good portion of your cherries to those doctors, your cataracts, your LASIK. Because right now there's a lot of cherry picking. All right, that's my soapbox for that.
And not a lot of specialists.
Yeah.
We do have a question. It's what structure of the angle would you like to see before SLT, and how many quadrants?
Great question.
So
go ahead, Ian.
For me, I'll do SLT if they're PTM 360, but they indent a scleral spur. But I always use pre-op pylo, and then we'll use lens tilt, and have them look in different directions of gaze to be able to apply the laser to the PTM. If there's PAS, then I'm very hesitant to do SLT in that situation, because they likely had some sort of intermittent angle closure, whether it's a previous appositional closure or maybe even a uveitic component. And if you SLT that, then your risk of increasing PAS is much higher. But if they're open, you can see the structure, you can do SLT. If they're a previous narrow angle patient and you deepen them, let's say they're ATM 360, but they were appositional and they indented scleral spur, you do it a PI, now their angle's open, you can still apply SLT to that patient after their LPI, as long as you can visualize the angle.
And one of the tricks too is it's not always just about what you can see, but how acute does the angle look. And there's some gonioscopy, grading systems that say, well, how many degrees is it? And it's like, oh, I don't know. I don't think you could ever say how many degrees it is. That's kind of hard, because from that perspective, looking head on, unless you have a textbook that's 3D that shows you this is what 10% looks like, this is what 10 degrees looks like 20. But you will get a feel just doing lots of gonio if something looks kind of like a narrow but angle or not. And even if you can see a lot of structures, if it's kind of slit out there, I'd be a little worried about the energy encouraging PAS if it was really narrow, even if you see structures. But that's just something you'll get a feel for over time. When in doubt, just what would you do? Like start with less energy, or just do 180? Like, I'm kind of worried about them having a negative response.
Those are good tips. Yeah, that's a great tip. And obviously, when you first start out, do it on people that are ciliary body 360 with 2+ pigments, so it's easy to know where to aim, and you got a lot of visualization, and then as you get more comfortable, you'll be able to identify those angular structures and get your laser where you need to go.
Yeah, thank you both so much.
Definitely our pleasure. As I enjoy doing this, I have a lot of fun. So
perfect, thank you. We'll make sure that we do this again next year.
All right, guys, we'll see you in the clinics.
Thank you all.
Bye now.